I'm going to go live. Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along and they'll be addressed. I'm honored to introduce our mentor for today, Dr. Callahan. Dr. Callahan is a pediatric pulmonologist in Baltimore, Maryland, and is affiliated with the Ascension St. Agnes Hospital. He received his medical degree from the Rowan University School of Osteopathic Medicine and has been in practice for over 20 years. He has served in multiple leadership roles and currently serves as the Vice President of Population Health at the University of Maryland Medical Center. He's also shared many roles with the Baltimore Convention Center Field Hospital in Baltimore, Maryland, which is a disaster hospital helping treat COVID patients during the COVID surge. And now I'd like to turn it over to Dr. Callahan to begin today's session. Thank you.
Thank you. Thank you so much. What a privilege it is for me to be here. I really appreciate the time this morning and the opportunity to tell a little bit about a story. All of us have a story, and what you're going to find out, I think, in the practice of medicine, that the real joy of this is getting to know other people's story. In fact, it never gets old. I've been a pediatrician for coming up on 40 years, and the thing I remember, the thing I think about are people's stories. So I want you to hold on to that. It'll be kind of a theme as we go through this. I practice pediatrics at St. Agnes Ascension. It's different than my hospital, but my affiliation is primarily with the University of Maryland Medical System and Medical Center. And I hope very soon to have turned over some of the contingency operations and begin to do that more. I wanted to just point out, I have a non-commercial blog site. Some of what we talk about is in there. It's called Henry V, Act 4, Scene 3. That's where that quote, few we happy, few we band of brothers, comes from. Again, it's non-commercial. I just put it out there because some of the stuff that I talk about needs a place to live, so people don't have to sit there scrambling. And the other thing is I've kept a lifelong sort of list of leadership books. This is a slide from before the pandemic. It has been updated, but I encourage you to do the same thing. As you read things, keep a list of the things that you think have been really helpful on your journey as a provider, as a physician, as a leader. And that's what this blog site represents. All right. So you already heard the beginning part of this, and you know I love technology, but I'll go through this very quickly. The beginning part of it, we talked a little bit about story. I told you about a non-commercial blog site and a reading list, and I wanted to get into. I'm gonna blast through story. I watched some of the previous speakers and they told a little bit about the background. I'll do the same thing. You know, that's me holding my pet bird as a boy. I mean, so I had an interest in ornithology from the beginning. You know, usual kid stuff. Went to college at Rutgers College. Did not get into medical school my first year. I'm very happy to talk about that. Ended up instead, my ROTC led me into the military, which I ended up doing for a lot of my career. Married before I knew I was going to medical school, and then accepted 3 days before classes started. So I became a medical student at the School of Osteopathic Medicine, and eventually got onto a military scholarship. I graduated in 1984. I became a general pediatrician first, practiced for 3 years, and then got into pediatric pulmonology, and I practiced for 30 years in the military. So this was a very broad practice of both general peds and subspecialty peds. I eventually became a program director and then a department chair at a hospital called Triple Army Medical Center in Hawaii. I went there against my will. We ended up staying 13 years. We're talking about vocation and background. As part of that, I ended up, because they send everybody to war when the nation's at war, I ended up going to war in 2004. I helped run a healthcare system while I was there. And when I came back, the military found other leadership jobs for me to do. I ended up being the chief medical officer at Walter Reed. I went on to be a chief executive officer at a small community hospital in Northern Virginia. I transitioned to become the chief operating officer of the National Naval Medical Center when it merged with Walter Reed Army Medical Center. And then I finished my military career the last 2 or 3 years of 30 as a hospital CEO or hospital commander, they called it, of a larger expanded brand new hospital at Fort Belvoir, Virginia. So that's my healthcare leadership background. I mean, other parts of the vocation include this very strange relationship where you sort of lead tours of these medical centers. That became an important part. But then I left in June of January of 2014. I transitioned out of the military. One of the first places I ended up with, that's when the Ebola epidemic happened in West Africa. I ended up in Sierra Leone that year taking care of patients. I love the privilege of being able to talk about pediatrics. This is the 2017 American Academy of Pediatrics meeting. And then my wife and I have settled in Baltimore, where we are involved in the community. We live in West Baltimore. We're involved in the community. And that sort of provides a little bit of background on the vocation. I love music. I love anything in the water, and my wife and I are continuing to watch birds, so we've gone full circle on that. The meta narrative from my life, I approach life sort of from a faith standpoint, and that's what that means. People ask me, what is my sort of faith? And I try very hard through the course of my life to sort of be a follower of Jesus. That's just my background. And then by way of context, the top left are the old gangster 7 kids that we had. We were surprised by twins at one point. Then we ended up adopting twins who are now 28 years old. So that's really the background. We're in Baltimore now, and this is really our home. That's where I've met your host. And we'll talk a little bit also about that particular last 3 years. Today is the last day of large-scale testing and vaccination, which was part of what I've been doing for the last 3 years, and in fact, where I met your colleagues. So this is the basis of my bias. This is kind of that whole story sort of tells you my angle on things. And it's important for you to know the story for the people that you work with as to the degree that you can, but also your patients, because it really colors their own perception of illness and so many other things. So the value of story is not just the delight that you can take in being able to look back, but also it gives you a unique perspective on patients. We talk about patient context and what things are going on with patients, and that becomes a very important part of it. I want to start by talking a little bit about pediatrics and some of the lessons we've learned. And what I want to focus on is one of the tensions in pediatrics. Now I'm going to shift to some slides that are a little bit older, so bear with me. I hate when there's different backgrounds, but I did this by necessity because this is a talk that I've been giving for a long time about this tension between healing and caring for. So it's the idea of concepts of care. What we think about when we think about the business we're in is healing. And the ancient Greeks had 2 separate words for this. One of them was eomai. We get the words iatrogenic from that, and it has to do with the physical healing. But then there's another word, therapeuo, which is really about healing, serving, caring for, and restoring. And it's a much more appropriate word for dealing with adults and children with chronic disease. So the idea of healing, taking away symptoms, relieving suffering, relieving physical pain. We live in a culture that wants not to have pain. And so we often look at diseases as acute or recurrent acute, and the priority for children anyways to make it all better. I learned this in the context of my first pediatric practice, which in those days, because we were an isolated place with a lot of children, we were booked 12 acute patients an hour. So it was a very rapid turnover, and the ability to pull chronic out of the context of acute or recurrent acute became an important skill early on as a general pediatrician. But pulmonologists end up getting involved with chronic disease. And so this word therapeuo, from which we get the word therapy, became a very important principle. It began with recognizing the role as a healthcare provider as a servant. And once you can get your mind around that, it's much less about me and my time and more about being able to be available for this panel of chronically ill patients. In my case, it was patients with sickle cell disease and to some degree, sorry, I meant cystic fibrosis and to some degree sickle cell disease. You can tell I've been in Baltimore for a while. It leads us to ending sort of paternalism and condescending attitudes. We see our patients or clients, my wife is a social worker, as priorities. It leads to a level of respect for them, recognizing that a child is more than his or her disease. And I would not kind of let my residents get away with referring to people by their disease. They're a diabetic, they're an asthmatic, they're a sickler, they're a leukemic. These are individuals who carry the burden of disease, and recognizing that helps them to see that the disease is not the total definition. Very quick sidebar. I really have always resisted calling patients by their first name, and pediatricians like the colloquialism of mom or dad. So I really try to encourage people, use people's titles. They're going to call you doctor. The least we can do is call them Mr. or Mrs. And in the military, I used rank. Tried very hard to do that. And I think it's been well received through the years. So the first part, as I said, is to serve. The second part is to care for. It's broader than the idea of healing. It involves rest and nutrition and hygiene, the things that we as medical students, at least in my era, didn't pay attention to. And it really leads to the coordination of medical and social services, an interdisciplinary team approach, having the parents or the patient's voice a part of this, a partnership in care, rather than I'm going to tell you what to do, and if you follow my rules and guidance, you'll get better. And then when they come back and they're not better, the natural response on the part of the providers when we embrace that way of thinking is to blame them for the not better. Well, you probably didn't take the medicine, or you didn't. And they end up feeling guilty, and it gets into this whole cycle. So stepping back and recognizing our relationship. Our goal is to restore. We want the child to lead as normal a life as possible. Normal is a very difficult word to come around. So without any bias, healthy relationships with their parents or caregivers, with their siblings, with their peers is what we're after. And so getting back to my introduction, helping the child to enjoy a vocation, making sure the parents recognize that every individual has some set of talents. This author, Marcus Buckingham, called it a recurring pattern of thought, feeling, or behavior that can be productively applied. He believed that every person was better than 10,000 people at something. And as an example, he talks about individuals with a talent for striving or thinking or relating, but helping parents to look for those things in the lives of their children, and adults to begin to see it in themselves. And also children enjoying an avocation, activities that they can participate, a variety of therapists. You may need to overcome negativism. Children who have asthma, who don't exercise because it makes them wheeze or they're afraid it'll set it off, they need to exercise. We as providers need to help them to be able to do that. A chronic disease is part of who the child is, but it doesn't define them. It's an essential recognition for the healthy transition to adulthood. If the disease is the sum total of who they are, and the disease is the sum total of how the parents relate to them, it's going to be a rocky transition to adulthood. And so there are these stages of disease transition. When the parent first has a set of problems and they come to me and they're not growing, they have a chronic cough, they have chronic loose stools, and I look at this baby because I've done it so many times and I say, holy mackerel, this baby has cystic fibrosis. The parents own the symptom complex. I am the first one to begin thinking about the likelihood of this becoming this chronic disease. I have to turn around and pass that ownership off. The sweat chloride test is positive. The baby does indeed have cystic fibrosis. You, mom and dad, mother and father, Mr. and Mrs. Jones, you have to now own this diagnosis. It can't just be mine. And ultimately, through the course of the second decade of life, that child who's becoming an adult has got to take ownership, his or herself. And so those are all important stages as we go forward. And we won't go through the stages of development, but what I try and encourage the trainees to do is to consider development in the transition of the diagnosis of a disease, which is a part of who they are. And that's something that they have to take on as they sort of move forward. Take a deep breath. I wanted to pause for a minute. That is just a very quick overview, one of 4 areas I hope to touch with you today. But I'll pause to see if anybody has any questions, and if they don't, I will go on. And I'll apologize in advance. I truly have only had 2 coffees since I got up this morning. So the freneticness of it, I will try and be a little bit more calm, but I also want to be so respectful of your time, those of you who are joining later on the YouTube and those who have joined in this morning. Any questions or comments? And I cannot see the chat very well. So if there's anything there, you'll have to help me with that.
And yes, Dr. Callahan, we're compiling them, but no questions as of yet.
Excellent, thank you. I'm going to go on. Thank you so much for your attention. Let's move on to sort of the next thing I wanted to discuss, and that is this concept of healthcare leadership. And let me start by telling you that you're already a leader. The fact that you're in healthcare, the fact that you're a provider, the fact that you're a physician, it puts you in this position of leadership. And I wish we had 4 hours to talk about this. That's the privilege I get occasionally, or before COVID, we would teach a unit on healthcare leadership to rising vice presidents in the military healthcare system. And this block of instruction was to help them to see themselves as leaders. They already had gotten to that point, but also to recognize the value of horizontal leadership. Leader does not mean boss, but leadership is nothing that it's not something we ever become an expert in. We're learning it as we go along. It is a valuable investment for you to take the time to see yourself that way, because as it turns out, the principles of leadership applied to your own personal life make you better at a range of different things. And we'll talk about that as we go through this. Better father, sister, partner, brother, sister, friend. And so leadership is life is one of the things I like to say, an assumption. And finally, leaders are born, they are raised, and they walk into situations where they demonstrate leadership in healthcare. So I like to say that leadership is a matter of nature, nurture, and knocks. opportunity knocks and people step into it. We're just going to highlight a couple of things very quickly in leadership. I've already told you a little bit about the privilege I've had at experiencing senior hospital leadership. And really what I don't have time to talk to you about is the tremendous teams that have sort of, I've had the privilege of being a part of in each of these sort of 5 roles, which span from about, I don't know, the late 90s to currently. I also am not going to talk very much about leadership here at the medical center because it's a separate conversation about leading population health in an area where the median income is $20,000 a year, and health-related social needs and the broader social determinants of health are really essentially what define the population that we get to care for. And nested in all of this is a story of a major American city that was built on principles of structural racism. And we don't have time to talk about any of that today, but I could come back another time and tell you that because it's such an important message. Here's the model for leadership that we developed. We called it FORCE, and it's 4 principles, and we'll go through a couple of these very quickly. Each one of these is sort of its own seminar. FORCE means we start with character, which means the ability to lead ourselves. Competence, which is the leading other people. A context, and by the way, the context is not about being a good pediatrician or a good surgeon or a good urologist or radiologist. It's about the skills that go into being a good leader. I've already told you some of those skills also make you a better human being. And I love the overlap between those things. Context is leading work. Every time you take a new job, it's a different context. And then finally, skills around communication, which we all need to know as providers. We need to know them as physicians, but as leaders, they become even more important. And the bigger the organization, the more crucial they become. The ability to sort of speak off the cuff, to tell a story, and then to communicate that. And we'll hit just a few things on these. This is another way to look at that model from the Uniformed Services University, where I hold my primary academic appointment in pediatrics and military and emergency medicine. This was the core model. I love the quote that all models are wrong, but some are useful. This model has been modified by the Uniformed Services University, and they're just beginning to roll it into a leader-follower framework. But in this framework, we talk about character, competence, context, and communication, and we look at it at the personal level, the interpersonal level, the team level, and the organizational level. And as you can imagine, there's a whole lot that goes into this. In fact, the medical student curriculum at the Uniformed Services University in Bethesda, Maryland, is built around a framework of leader development. Their first lecture is about the importance of emotional intelligence, which informs both healthcare and leadership and life, parenthetically. I wish that someone had talked to me about emotional intelligence before I had teenagers. So I think the later ones did much better than the older ones, because I don't think I was really skilled at this. So what are the cardinal practices of a leader? We're just going to hit these very quickly. The idea of reading and gaining knowledge about the subjects around leading others. The ability of writing, I can't underscore that enough. Rounding, being out where your people are. And even when you get to the level of being in a clinic, or you're part of a healthcare team, or now you're the second-year resident, you have interns, to show up there more than just, when rounds are happening. And then the ability off the cuff to be able to remind people why we're here. And healthcare has got such a dominant narrative, such an important narrative, that it's easy for us to forget and assume that people understand and don't need to hear it. Here's 4 B's of Leader Foundation. One of them is to read the basics. I already talked about reading. Another is to read biography. When I was a young pediatrician, 2 years out of medical school, I wrote an article that was published in Peds in Review about what it meant to be a general pediatrician. It made its way somehow, and I got a note in my mailbox from a general officer said, "Great job on that article. Keep up the good work." And he just said, "Scotty." And that was back when mail came to your mailbox, by the way. I thought that meant so much to me, such a shot in the arm in the middle of Texas, where I was a general pediatrician, to think that somebody that senior in Washington, D.C. thought about me. I copied that. I stole it from him. And through my whole career, when someone has helped me or someone has done something, I would write them a note. As a hospital CEO, I told all the department chairs, when your department members publish a paper, I want a copy of the paper and their address or their name in my office. And I would try and read the paper and write them a note. Again, that's reading biography. Look at good people, good leaders, steal from them mercilessly, and look at leaders that you think are bad leaders and say, I'm not going to be that kind of a leader. Whatever your book is, that is your philosophy or your faith, I would really encourage you, as busy as you are as medical students, don't let that go. Find time every day to recenter yourself. So whatever your book or your belief set is, I return to that on a daily basis. And then have somebody that you can talk to about how you feel, what you've just been through. I've been blessed to have a wife who's got a first graduate degrees in counseling psychology, and the second is in social work. But any kind of a partner or friend or someone that you trust, someone either at work or not work, that you can sort of unload on, it's really the only way to get through what you're doing now and what you expect to be doing in the future. So have that 2 deck chairs on the balcony is one way to go forward. Here's 4 more B's. The first one were just letters, and the second one were the things to be. And that is, as a leader, as a medical leader, we have no right to ask anyone to do anything that we are not modeling ourselves. So just this phrase, be the man or ma'am, but the idea of setting the example for the people that we have the privilege of walking alongside of. We have no right, as I said, to hold them accountable if we're not there with them. I had an orthopedic surgeon one time tell me, well after I had retired, he was on his way to retirement. I was his chief medical officer for several years during the peak of the war, and the soldiers were coming back in. And he said to me, you know, you were always in the operating room. Well, I knew I wasn't always in the operating room, but he was telling me that I was there enough as a chief medical officer with them on holidays and weekends, so that it didn't seem uncomfortable when I was there. We have to be an example. We have to be present where people are. So be the man or ma'am. The privilege of medicine is that we get to be the one. In those moments, the best moments of people's lives and their worst moments, we get to be there with them. And we can brush right past that if we're busy thinking about other things. So never lose sense that we have the privilege of being the one at that moment. We'll talk more about this, but Gunther Gable-Williams talked about this principle when he handed off the lion taming business to his son. And we'll expand on that in 1 second. And then finally, Gandhi said, be the change. A lot of times we think everyone else should change around us to accommodate kind of who we are. And I got to tell you that gets worse as you get older. But be that change. Recognize that the change that needs to happen begins with us. And then I will just emphasize, so Gunther Gable-Williams' advice to his son, when you go in to that lion cage, the foundation of sensitivity, as it says on here, is you need to be there. You need to be present. And I got to tell you that is true in the practice of medicine with your patients. Be present. In a 5-minute appointment, I just learned to sit down, lean forward, look into the patient's eyes directly, and mirror their face with my face. If they were happy, I would smile with them. If they were worried, I would furrow my brow. It was a discipline to me to look beyond what they were saying and really hear what was behind it. So be there. And in fact, when my daughter called me on her bicycle in the dark, and she's a nursing student in Miami on her way to her first clinicals, my reflex was to scold her about not having her helmet on because I knew she didn't. But she asked me, what advice can you give me on my first day of clinicals? And I'm standing in my office. I could picture it was like yesterday. What a privilege, right? To have one of your children ask you advice like this. Now, my daughter and I had worked in a hospital in Togo in West Africa when she was a nursing student, and I was a pediatrician just out of the military. So we had this kind of a health relationship. She still calls me with her good days and her bad days, and I can't tell you what a privilege that is. But my advice to her was, remember to look into their eyes. And as I look back over 4 decades, one of the most important practices that I think I learned by accident, because no one ever told me, was that privilege. And I'm telling you, I started practice before EMRs. It's harder for this generation because you're constantly looking at the screen. You know you're falling behind, and the ability to be able to look in your patient's eyes. So remember to look into their eyes. I would say that about your peers and as leaders, subordinates too. So hold on to that principle. It relates back to this phrase I really love, a Zulu greeting, Sawubona, I see you, and the response back is Sikona, I am here. The idea of presence in leadership, so important. So we talked a little bit about character. We talked a little bit about competence. Context is knowing what needs to be done. Remember that medicine is inherently tactical. We learn one patient at a time, We learn one situation, one operating room, one exam room, one hospital bed on the inpatient ward. And so this tactical sense trumps the bigger picture. We need to understand patients in a bigger picture. And some of the bigger picture parts of both our patients' lives and our healthcare system's lives have to do with the people as a group, what they're collectively experiencing, the practice as it pertains to them, and then the places where they get their care as healthcare professionals in leadership roles. These are the three major principles that shape a healthcare system. Paul Farmer liked to summarize it differently. He called it your staff, your systems, your space, and he would add your stuff in there as well, your medicines and your bandages and so forth. And it's not unique. The humanic, functional, and mechanical, what Leonard Berry summarizes in his book about the Mayo Clinic. So this is how we understand the context of our patients and the outcome on the other side, what we're looking for in any relationship, whether it's a relationship with a patient, whether it's a relationship with the patient's family, whether it's a relationship with a healthcare organization, the healthcare team, the ward where you work, the team where you work. What we're looking for is people to center on a shared reason. That is the care of the patient, the betterment of the patient. In public health, it's the end of a pandemic. It's the end of an epidemic. Shared reason and coming back to that repeatedly. Shared risk means that I may not be able to do what you do, but I'm going to stand next to you while you're doing it. So for us here during COVID, we ran a large 250-bed COVID hospital where we turned 138,000 square feet of a convention center into a hot zone hospital. And I did not provide direct care. I'm a pediatrician, and we had all the patients were 18 and up. But I was there every day that I could be there, weekends, nights, because we had people in there caring for them. That's the idea of shared risk. And then finally, a context and a situation where people respect each other. And you got to watch this, because my pediatric ICU director, when I was a department chair, presented a patient and said it was just another dumb family medicine doc. And I took her aside afterward. I said, you know, the thing you said in there, don't ever, ever say that again, because that demeans someone who's doing something that you have no idea about. You've never experienced it before. And she was sufficiently recalcitrant, I have to tell you. And she never did it again. And she has gone on to have a really glorious career and as a program director, fellowship director now, remarkable woman. But the point is, you can't tolerate a lack of respect in any one of those settings, either towards patients, their family members, their background, the people they come from, the city part where they live. Watch people grouping, saying those people, if only those people would get a job, if only those people. That is disrespect, and it has no place in a healthy leadership climate. Quickly, learning to communicate in a leadership setting. The first step, sometimes we're not paying attention until we think it might have something to do with this, and we're ignoring it. And my kids taught me this. Wait, what did you just say? Yes, you weren't listening to me. Let me start all over again. This Saturday, we have dental appointments. So you're going to be a little late for soccer practice. That's the kind of a conversation. So the first phase is ignoring. What I used to do was I would listen to it until I felt like I didn't listen to it anymore. And I would say, got it. I did that exactly one time with my wife. And she leaned forward and said, no. You don't tell that to me, because part of the process here is you've got to hear me out on this. I almost did it this morning when we were a little pressed for time and I knew I had to get to the vaccine site and I was going to get back here. I almost got it with her this morning. I just know, my kids swear I have a little attention deficit problem here, and I've self-medicated with coffee all my whole life. But the idea that we hear it, but we're not really paying attention. Listening is understanding what's behind it. But more importantly, attend comes from the Latin word to reach out, to grasp, and understanding the feelings that are behind what's being said. That takes time, and we don't normally give it. That takes attention and intention. And I'm scrolling through my phone at the same time. I am not giving up either. So these are important elements of communication. And one of the things I've learned as a leader goes back to the 25th century, before Common Era, before Christ. Those who much listen to the pleas and cries of the people should do so patiently, because the people want attention to what they say even more than the accomplishing for which they came. That's priceless, and it's timeless, because people want to be listened to even when you can't help them. They want to be listened to. And that goes for adolescents that you may be raising as a parent or as a foster parent or as a friend or as a mentor and some of the volunteer organizations. And it certainly goes for our patients. Look, Chronic disease, bad prognoses, these things are terrible. And physicians who are trained to heal and make them go away, we sometimes don't want to hear about it. How about this as a healthcare leader? You've had an unanticipated outcome in your healthcare system. You don't want to hear about it, but the person you need to go eye to eye with right away is the person who was the subject of that, or the family that was the subject of that. And you do those practices, you lean forward, you mirror the attention with your face. They will say, you are the first person who ever listened to me. I can't do anything to bring back what happened, but I can walk with you and sit with you through what you're experiencing. And all I can tell you is I wish someone had told me this sooner, but it's invaluable to me. And in fact, it's been around for 27 centuries or whatever it is. I already talked a little bit about writing and rhetoric, the idea of being able to send out emails. The bigger your organization, keeping people in touch, sending out a quote of the day in some way, and then being able to spontaneously tell the story about your service, tell the story about the work, tell your story about pediatrics. You're the second-year resident on a pediatric service, and there's a medical student there. What is the story about what it means to be a pediatrician and how important that is, and what a privilege it is, not only to care for a child, but to help parents figure out how to care for a child. I've never regretted a moment, but that becomes part of the rhetoric around that story. Here's some very quick bottom line stuff. Bad leadership is common, but nobody gets up in the morning and says, today I'll be a bad leader. Sometimes bad medicine is common, but no one gets up in the morning and says, today I'm going to be a bad physician. I'm going to be a bad provider. I'm going to be a bad healthcare leader. And that should be sobering to us. Same is true as parenting, by the way. I mean, there's lots of people that are bad parents, and I've been one myself many times, but I didn't do it on purpose. And that's why consistently good leadership, parenthood, healthcare leadership is intentional. And when you have mistakes, it usually falls into these buckets. And the one I see most of the time is we've got the wrong model in mind and we apply it to the wrong setting. It's the wrong style. It's the wrong subject. We're talking too harshly. We're not slowing down. We're not paying attention. We're not listening to what needs to be said. And we end up making the mistakes of flawed competence, flawed leadership competence, but flawed physician competence as well. The ability to be able to sense in a busy day of 24, 26 patients and a whole bunch of phone calls you have to make and a patient you need to visit in the hospital, the mistake of not paying attention to the three that really needed you to be present with them that day is something that we will always struggle with as providers. And we need to begin to develop tricks to bring us back to focus on that. I'll pause there. That's a little bit about healthcare leadership, but as you can see, it sort of spills back into a whole lot of different areas. And I'll pause and see if anybody has any questions or comments.
Yes, Dr. Callahan, we have one question. I can ask Rob, and you can ask one of the questions that we had for leadership.
I'm looking to another screen, so I apologize if I'm looking away from the camera. Go ahead.
Hi,
Robin.
I'm Robin. I'm a PhD student at Johns Hopkins. I work with TeleShadowing. So we wanted to know, did you always know you wanted to go into healthcare leadership? And then what's some of your best advice for people who are like in medical school? Are there classes they should take or experiences you think are really important?
So I tell people when I have a longer time to talk about leadership, and I'd be happy to do that really to anybody in any context if you want, but I feel like I've been a student of leadership my whole life. I've just really watched people in leadership. There's a whole body of literature around which kinds of people end up in leadership. I'm an extrovert, you might gather that. And so that tends to, but it doesn't mean that extroverts are exclusively leaders. So I kind of feel like I always looked at it from that standpoint. Certainly from healthcare leadership, as a brand new pediatrician or a brand new peds pulmonologist, it was the last thing I wanted to do. I wanted to practice what I did. And what happens a lot of times is when we apply some of the principles we're talking about, people begin to recognize in you that there's something about you that they want to follow. And I think ideally, leadership is defined by the fact that you look back over your shoulder and that there are people there. I mean, and that's not something that you can really force. And so I've been very fortunate too, because I had people who came alongside me and said, there's something about you, but you really need to stop doing this. So, and yes, there are lots of things you can read about, lots of things you can think about. I am so encouraged because In the last 5 years, maybe a little bit longer, for the first time ever, I'm seeing people who are coming into healthcare because they want to become healthcare leaders. Look, I don't have time to talk about it today, but we've got a kind of a dysfunctional health system here in the United States. I mean, no offense to anybody, we've kind of inherited the wind on this one, but it doesn't mean it has to stay that way. And I wish I had more time to talk about this, but remember, I spent 30 years in what was essentially socialized medicine, and I'm kind of a fan. I mean, in the sense that I never had to worry. My daughter's got congenital heart disease. She had surgery 4 different places, and whatever she needed, she was able to get because I was a part of a system where nobody ever really asked whether I had insurance. So to answer the question directly, begin seeing yourself that way, begin studying that way. And I think that you begin, Robin, you begin to sort of find those opportunities. And when you do, when someone says, I need someone to get us ready for this upcoming audit or inspection, step forward. That's an opportunity knock. I guarantee that you'll learn from that.
And I think you make a great point about the change in the healthcare system. I forget who I was talking to, but they said something about in the hospital, more and more people are just showing up in suits. And they're like, I don't know what these people do. It doesn't seem like they even have a medicine background.
Well, since the pandemic happened, and we'll talk about that in a minute, I've stopped wearing suits. So, I mean, I want to go back. I want to be able to be seen as somebody that's on the ground. And I was at our vaccine site this morning. This is our last day of COVID vaccines here for Baltimore and this particular site. So, yeah, I agree with you 100%. I feel like I'm constantly learning, though, Robin. So it is not a journey that has a finish line. And I think I'm going to be saying that pretty much up till I'm not doing any of it anymore.
Besides what you've mentioned already, what's like your favorite book on leadership that you think everybody should read?
I have no financial interest in any of these books, but the one I usually point to first, and especially when I'm in a mentor relationship, is a book by Daniel Goleman called Primal Leadership. I think it's written in 1992. It's still a classic. And it basically is the application of emotional intelligence to the practice of leadership. And I go back to it all the time. I have a dog-eared copy of it. And that's one of the ones I really refer to a lot. Primal Leadership.
I'll have to check that out after this call.
Yeah, that blog site's got a reading list on it too, if you're ever interested.
Okay. One of the questions that somebody posted was they wanted your thoughts on John Maxwell's quote that true leaders create more leaders, not followers.
Oh man, that is not just his quote. It's all of. I will often say the first job of a leader, quoting a general named Shelley Kasvali. The first job of a leader, actually, no, it's a general named Creech. I got my quotes mixed up. By the way, I collect quotes. I just don't always remember them literally. But the first job of a leader is to create more leaders. So I absolutely agree that is part. I come from an organization where the expectation was that at any moment, anyone could take over. So that was, I walked away from this testing site. There were no other executives there, this vac site this morning. There are plenty of leaders. In fact, the encouragement was that every single person be a leader. Every single person is checking the doses and the vaccines and so forth and so on. So I absolutely think that that's an accurate quote. And we're successful. If everybody that's on this call and everybody had a chance began to look in the mirror and say, I want to be a leader in the healthcare system. I want to set an example. I want to show people what right looks like. I think that's the definition of success in a lot of ways.
So we just have one more question about this part of your talk. You've really emphasized how important it is to have these respectful relationships, like patient first mindset. What's your best advice for successfully navigating and developing relationships with patients who might come from a cultural background that you're not familiar with?
Yeah, I think, and I'm going to say this in this next section because it really came home to me when I'm going to talk a little bit about practicing in Sierra Leone. But the thing I would recommend, I'm a big fan, and I'll say it a lot, is names and narratives. The first thing we can do is the very best we can to get people's names right. People are flattered when you ask them what they like to be called and how do I pronounce your name correctly. And I would keep a piece of paper with the phonetic spelling of a name that I'm not familiar with. And so I think names, and then asking people the stories. One of the things I think about leadership is you ask people questions about themselves. And then when you get to the second question, what we naturally do, and I'm terrible at this, is we right away open our autobiography. So someone will say, yeah, I'm struggling a little bit because I lost my mother and this is the anniversary. And our natural instinct is to start talking about how we lost our mother. And that's not how we connect with our patients. That may or may not be salient at some point in the conversation, but I call it the art of the second question. If we really care, we don't just ask the first question, we ask the follow-on question. How are you doing today? I'm doing fine. Well, what does fine mean to you? Well, and then you ask a question, or what question do you have for me today? So a recent internist taught me that. And they'll say one question, and then you ask another question on top of that. It's so easy to basically, and you can tell I'm very good at diatribe. What you really want to be able to have is a dialogue with people. So names and narratives is a good place to start.
I think that's really great advice, because even just in general conversation, people are like, how are you? You automatically just sort of lie and say fine, because you're like, you don't care. So establishing that real connection, being like, yes, I actually do care. Tell me about how you're feeling.
Yeah, in fact, being married now for over 4 decades, the word fine has become code that it wasn't good. So if I say, how was your day? She said it was fine. I know that she really is telling me it wasn't a good day. And it's a cue to me to ask the second question. Yeah, fine doesn't usually mean good. What happened? And it's just like that. That's how we develop meaningful friendships. Why wouldn't we do the same thing with our patients and with coworkers? All right, let me go on, because this really could have been, as you can easily tell, 4 one-hour sessions. But I wanted to go on and talk a little bit about lessons from an Ebola treatment unit. And I'll go through this pretty quickly. So this is the summer of 2014. This is the outbreak of the largest and longest Ebola epidemic in history. At the end of all of this, there were 26,610 cases, and there were 11,309 deaths. And the mortality, though, in the summer of 2014 was 70% mortality. And it was at that point that Medicine Sans Frontières was asking somebody come help. And you could see it was sort of raging primarily in Liberia at that point of time. October of 2014, on a Sunday morning, I was reading Time Magazine, the Washington Post, that article, Out of Control. And I turned to my wife and said, they're a country without doctors, and I'm a doctor without patients. And she quoted actually a verse to me from the New Testament about, if you see your brother, if your brother is in need and you don't respond, how does that reflect the love of God? And I said, okay, I best volunteer. The next day I volunteered with USAID. Partners in Health picked me up right away. They were gearing up to put systems in place. I love Partners in Health. Many of you probably know about it. Remarkable organization. Got to know Paul Farmer relatively well. He died a year ago this past week. But a remarkable model of accompaniment where they go to a country and they stay there for a generation. And so when they went into Sierra Leone to set up treatment facilities, their intent was to stay there for 20 years. And so by December, I was at this former Red Cross school in Port Loco, which was an area not far from the airport, but south of Freetown. Just real quickly about Ebola, and we won't. I mean, again, this is a much longer conversation. I grew up sort of petrified of it, to be candid with you. And that top thing in yellow is part of what they tell you right before you go into the hot zone. There are 1 million viral particles in a milliliter of blood, and it only takes 5 to 10 to cause infection. And so that was sort of the sobering piece of advice. A lot of ritual around donning, even in what was a pretty rustic environment. This thing was built out of, you can see, out of wood and paper, plastic sheeting. A lot of ritual that went into the 15 minutes it took to put on everything exactly right. The basic standard gear. I wore 3 pairs of gloves. 2 were required. The third I called my Linda layer. My wife's name is Linda. So I was going to wear 1 more extra pair of gloves. And it was amazing to me how often that top pair would get punctured. And then very meticulous ritual, 60 seconds of chlorine in between each layer coming back off. And usually you had to go to the bathroom after 90 minutes. And so there was a lot of jiggling going on, but it was, again, rustic, but there was systems and rituals in place. We had a morning report with a very broad group of people. There were Cuban physicians, Nigerian physicians, Sierra Leonean. This was the leader of the unit there that you can picture there. And then there were expatriates like myself that were there with Partners in Health. Patients arrived in ambulances very often, and there was, again, ritual spray down the ambulance and everything else. They moved from suspected to confirmed. This is the suspected ward. Then they would go down a set of pathway to the confirmed. We tried to keep those 2 separate. This is a set of babies coming out of the suspected, and the woman on the little baby, the girl on the right, is a girl coming out of the confirmed after she survived Ebola. The first patient that I cared for in a unit. These are pictures that are used by permission. This is the morgue where I would go every day to check to see if the number of bodies that were in there that night. If they survived, when they survived, they tied a ribbon on this tree of hope that is still there. All the buildings behind it are gone. It's all been torn down, but this tree still stands there as a testimony. And I think it ended with about 160 ribbons on the tree by the time the epidemic sort of burned itself out. The way to stop Ebola, Paul Farmer said, was for us to stop looking at it as a third world disease and recognize that it is a subject, it is a problem of developing world healthcare systems. This is a baby that was found in a house. Her whole family had died of Ebola. Her age was unknown. She also had Ebola. I thought for sure on Christmas Eve, when we couldn't get an IV on and it became too dark, that she was going to die. The next morning, she was still alive. She recovered because we had one interosseous needle that we were able to resuscitate her with, and then we were eventually able to get an IV. She went on to recover from it, but developed all of the symptoms of severe malnutrition. So the background of protein malnutrition, you can see the peeling skin. If you could get a better look, her hair picked up this orangish color. And she's generalized edema. That's all protein malnutrition. So it's Ebola in the face of underlying malnutrition. But she is just a great news story and went on to sort of survive and thrive. This is her auntie who was able to be connected. Those earrings are significant because she had them when she came. She wore them while she was there. We soaked them in chlorine. It was just a little mark of humanity. And Paul Farmer writes about this baby in his book, Fever, Feuds, and Diamonds. Moving towards more organized care, we began to develop protocols. And as the case fatality rate began to come down, it was fueled in part because systematic approaches. This was our pediatric protocol. And it was based on nothing because there was nothing in the literature, but it was stuff we began to think worked. And we eventually organized this in a way that we would follow pretty faithfully. And when it was all over, some of my colleagues and I pulled this together into an article that was published in Journal of Pediatrics. Just the next time we're going to need to sort of know what to do. It was a great team, as I've already said, of folks from all over the world. And that's the point of this, is that people came from all over. It was relatively rustic conditions. But still, I mean, I think, very much survivable. We were there, I guess, better part of 6 to 8 weeks when I was there. I was not going to use a mosquito net. And I went to an infectious disease consultant. He said, African insects are not American insects. Use the mosquito net. So I found that out. This is a Nairobi 5 or champion bug. And the hemolymph contains a chemical that breaks down the skin. This kept me out of the Ebola unit for a day or two. And so here's what I just said. So when you talk about leadership lessons, master names and narratives, the principle of leading from the front, be the first person in, the last person out. Niccolo Machiavelli said the duty of a good general is to be the first one in the saddle and the last one out of the saddle. The ability to practice calm in the face of chaos. If you can stay calm, people will join you in it. If you become overwhelmed with the chaos, people will join you in that too. And so a lot of times it becomes a decision. And Napoleon made that point. Genius in leadership is the ability to do an average thing while everyone else around you is going crazy. So a lot of times it just comes down to doing an average thing. A code in the ICU in DC Children's, where I was a resident, I would watch one fellow as the code began say, "Get me an amp of atropine." And you'd hear the drawers open and close, and he would take the amp of atropine and he would look at it, he would put it on the bed, and then they would proceed. And I watched this 3 or 4 times. And finally I said to him, "What's the deal with the atropine? You always seem to ask for it, but I've never seen you use it." He said, "I'm never going to use it." He said, "I just ordered that so I can give everybody something to do while I can figure out what the heck I'm supposed to do next." That to me is doing an average thing while everyone else is going crazy. And I never forgot that important privilege. What I listened for as a hospital leader, I would go to the codes, I would stand outside the room. And the thing that I would say is I would listen for one voice giving commands and giving instructions. It's easy to get discouraged in the face of all this. We saw a lot of fish heads, and I'm not particularly fond of them. And so I didn't eat the fish heads. And it was months and months later when I was giving a talk like this, that a woman from Sierra Leone came up to me and she said, "About the fish heads." And I said, yeah, what's up with that? She said, you're an honored guest. The fish head is the most nutritious part of the fish. They were giving you the most nutritious part. So Robin asked that question about context. I had completely missed that. I did in retrospect notice that the Sierra Leoneans who were eating with us loved the fish heads and would eat all of the ones that we didn't want. So again, ditching disparagement, it's okay to complain to each other, but be very careful about whom you're with when you do that. And then it's very tempting to walk away, very tempting to find a reason not, when the novelty wears off, to not go up on the ward one more time when your gut is telling you that you really ought to go check on Sarah Jones or Mrs. Smith again one more time before you leave. So resisting retreat. A lot of times it is a combination of recognizing how bad things are, resigning yourself to the fact that things may not turn out the way you want, resigning yourself to that, but also resolve that you're going to do everything within your power to work towards an improved, whether it's a set of conditions or a patient's condition. And increasingly, people don't recognize the red pill from the matrix, but it is the red pill. It's being willing to see things for what they really are, as bad as they are. And the problem with Ebola had everything to do with the healthcare system and not necessarily. The disease is bad, but the mortality should be like cholera, 10%, 15%, not 70%. 70% is what happened when you don't have IVs. 70% was when you don't know how to isolate and stay away from other people. This is a community health worker who had just shown me his clipboard of the villages he had spoken to in the last 3 or 4 days to tell people about safe practices around Ebola. That community health worker, that's why Ebola ended in Sierra Leone. And it was actually coming down by the time we got to the new year between 2014 and 2015. And it begins to define a lot of what we look for when we talk about success. I love this quote that's been attributed to Emerson: appreciating beauty, finding the best in others, leaving the world a better place, healthy child, garden patch, redeemed social condition. Even one life is breathed easier because you live as success. And you are entering to the profession where this will be daily business for you. So never take that for granted. Questions? Anybody have any questions about this little section? We have one more to get through, and I know we're at the top of the hour, so I will, as you no doubt gathered, go quickly.
Yes, my name is Hamza, and I actually do have one question about the section. So after the recent earthquakes in Turkey and Syria, I know that there are many people here who may be interested in getting involved with Doctors Without Borders in the future. Can you tell us a bit about how you got involved and how we can get involved in the future ourselves?
Yeah, I will tell you, it's interesting. Doctors Without Borders, Médecins Sans Frontières, my French is terrible, are among the most selective of those humanitarian outfits. I'm a big fan of Partners in Health from a number of standpoints, partly because MSF has the reputation of going to the worst places and putting themselves at risk. I mean, they eventually had to pull out of Afghanistan, but it wasn't until lives were lost. I mean, to me, they're just heroic women and men. But Partners in Health, I like the accompaniment model, and that is where they go and they stay. My wife and I were gearing up to go back when I really didn't have any other job. And we, as you already saw the pictures of my family, we have a lot of children. And in that context, there's some with behavioral health, mental illness challenges. And so we elected to stay, and it was actually a good decision for us, at least during this season of life. But so I would look at all of them. What they really need is the expertise that you are developing. So I would really encourage you to become your highest priorities, become the best clinician that you can be. But to the degree that you're able to do short-term things in the interim, I would jump at those opportunities if they're offered, because every one of those experiences, I think, helps and adds up. I was amazed when I got to Sierra Leone, and I said, I'd done some stuff in the military. I mean, there are people that had been on 12, 14, 18 missions, and there was a whole subculture within medicine that this is their lives. They go back to their job in the ER or to a hospital until the next major earthquake comes, and then they're over there in the middle of it again. And I'm very thankful for people who are called to that. So don't give up on that. In the meantime, learn everything you can, both from a clinical standpoint, but also from a public health standpoint, because you end up having to do both.
All right, thank you, Dr. Callahan. We can continue with the next section at the talk.
No, what a privilege it is. I'll say that a million times. Let me finish just real quickly with, I did not see this one coming. I mean, who did, right? Who ended up seeing this coming? But Baltimore pulled together beginning actually exactly 3 years ago, 2 days ago, the 23rd of March of 2020, individuals from Hopkins, Maryland, and the Maryland Department of Health with the city of Baltimore came together in the Baltimore Convention Center. That's the convention center in the top here, to set up a 250-bed hospital. And you can see a picture of it there. And then added on to that other public health missions, a mass testing site that it was initially at the convention center and had subsequently been all over the state. Mass vaccination site, the state's largest therapeutic infusion, COVID infusion program, which is still ongoing. And there's some lessons that come from that. And I'll go through it very quickly. The charge to begin to establish the hospital, this was the blank slate that we began with. These were the partners that sort of came together in that context. This was the beginning of a mission analysis. So suddenly pouring ourselves into it, we had 1 month to go from an empty hall to a hospital. And between the 23rd and the 28th was when all the equipment was delivered. Working with a team of folks that had never worked together before. This is another Army officer, retired. We had known each other when we were in the military. Jim Fickey's the chair of ortho at Hopkins. And he became the director and I became his co-director, setting this up. But the rest of these folks I had never worked with before. We had never worked with before. So pulling together a team very quickly. And back to Robin's question, names and narratives, knowing names right from the beginning and getting to know sort of people's stories. This was the construction day on the 28th. The National Guard came in. And when we got to this phase at the bottom, I said, wait. This is the hospital? This is what everybody was talking about with the SPEMA hospital? And it was really the bare bones. The ironic piece of it, and you can see the crates that it came in, we really didn't end up using very much of this hospital at all. And in fact, went back to the well to bring other things online. You can see them beginning to construct in the back the actual 10 by 10 rooms of this 250-bed hospital, and some of the dry runs around practicing the clinical programs, which really we'd never done together. This is interesting. This is the chief of pharmacy from the University of Maryland Medical Center, and he was there all the time. The resources we had of people on the ground to make this happen was just, I think, a big part of the success. It was also moving from this model of sufficiency of care to standard of care. From the very beginning, we were not going to be settled. We were not going to settle with just sufficiency of care. I think that's as far as a lot of contingency operations got. But because we were all hospital people, because we were all working with an EMR, we resolved that we were going to move very quickly. And so there's the concept on the left. This is how it sort of played out on the right. It was continually being modified. It's 132,000, I think, square feet. This is a shower trailer for our patients. A whole lot we could say about that. Very sophisticated donning and doffing areas. Rituals. This is one of the donning, the doffing areas. Doffing in pairs to make sure that we were doing it accurately. Donning in pairs to make sure that it was well supervised. As I said, this culture of flexibility led to mass COVID testing, mass vaccination, regional care coordination, and all of the principles we talked about leadership came home to roost in this. There's really nothing that I've talked about that we haven't applied in these last 3 years as part of this operation. And essentially that's the context of this last quote, that all of the leadership applies and branding matters. It's funny, this logo, when you started with it, we worked with the state to come up with the name of the organization. We had to come up with it. And then when we closed the convention center site about 18 months ago and continued almost 2 years, and we continued as a task force carrying that brand with us. And the brand was characterized by patient safety, optimal patient experience, and the highest level of quality care, not sufficiency, but standard and exceeding the standard. And what I've told this team repeatedly, and I really believe it, and when you look back at this, this is what right looks like. This is what healthcare should be when right looks like. We were well-resourced, I get it. The state did a wonderful job. We were always supported by MDH. The answer was always yes before we even asked the question. And now we're in that phase where the pandemic is under control. And in the last week, we've had 2 sessions of working with the new administration and the new Secretary of Health, and are moving rapidly towards saying, okay, our mission is finished. It's time to turn that over. And in fact, when I hang up here, I'm going to go back to our large testing site, a 10,000 square foot tent for what is our last day of testing and vaccination. So that I just wanted to sort of summarize with, and actually that's really the second to last slide. And I'll pause there and see if anybody has any questions or comments.
Yes, there's one more question related to this. So you showed us how many organizations in Maryland got together to set up a hospital in the Baltimore Convention Center. Do you think the reason that the project was successful was because of the cooperation between the many organizations involved?
Yes. So I tried as hard as I could whenever the newspaper would ask me what was the success. The success was the public-private partnership. Uh, we talked to other states in the United States who could not figure out how to get this off the ground. And one of the states told me, frankly, they couldn't get any of their healthcare systems to step up to the plate because they didn't want the liability. Remember, at this point in the pandemic, you were talking, 2020 going into the summer of 2020, a lot of it was a mystery. And things could have gone south. And a lot of the healthcare systems were like, look, we're just going to take care of ourselves. But what the Maryland Department of Health and Secretary Dennis Schrader did with Governor Larry Hogan was to say, we're going to get both anchor institutions from Baltimore involved, the University of Maryland on one side and Johns Hopkins on the other. We're going to come together with the city of Baltimore owns the convention center with MDH, and that partnership, bringing in issues like MEMA and FEMA, our emergency response agencies, that's exactly the answer to the question. It's the public-private partnership. Now, I will tell you that the military experience was helpful in building a team from nothing, because it's something that we've done before. My colleague Jim Fickey ran a hospital, in a combat zone, and I helped run a healthcare system in that setting. So a lot of the principles came to bear around contingency operations. But I will first and foremost attribute that public-private partnership. I think it's a very perceptive question.
Thank you. That was the question we have for this section.
Okay. Well, last thing, I just want to leave you with this thought, and that is that, and we've said this thing about names and narratives, and what I believe, looking back over now, 4 decades in clinical care, I like to tell people that the greatest joy of healthcare is the fact that through the course of that, you get to know people's names and their narratives. I'm better at the narratives than I am at the names. And it's amazing to me how they just come back to you. I was just standing this morning, we started talking about asthma when we were over in the testing area, and all these stories come flowing back out to me about clinical, and it really is the joy of healthcare. I'm going to drive my children and my grandchildren crazy over the remainder of my life. They're going to say, okay, here goes Pop again. He's going to tell us that story about whatever the story happened to be. But it really is the joy. I mean, I love putting in A-lines. I loved taking care of critically ill kids. I love the science. I love the research. I have loved learning about COVID and adult medicine, how it interfaces with diabetes and hypertension. I love that stuff. But the real joy is knowing that these patients and their families, their stories have become part of my story. And here's the real privilege. The real honor of medicine is the opposite of that. The real honor of medicine is that you become part of their story. 2 weeks ago, I got a cold call on my phone, and the person who answers the phone said, there's this guy in New Jersey who wants to talk to you. He said that you helped take care of his son. And I called him back and he said, Doc, you don't remember me, but there was a day when my baby got admitted to your hospital and I was working in Philadelphia as a pulmonary fellow then. And you physically restrained me from punching the doctor that was taking care of my kid because he wasn't giving me the answers I wanted to hear. He said, do you remember that? I said, well, I don't really remember it very well. He told me a little bit more about him, and I remembered that piece of the narrative and then remembered the story. He said, my wife and I were just talking about that. Our son's 32 years old now, and we don't think we ever thanked you for that. And I just wanted to find you. So he tracked me down and said, thanks. That's the real honor of medicine. And you won't always get those calls, but you'll always know that you become part of somebody's story forever. I had a cancer diagnosis when I was the chief medical officer at Walter Reed Army Medical Center, and I was a patient in my own hospital. And the first embarrassing thing was there were people there that didn't know who I was. Okay, so that wasn't very good, but it was a big hospital, 500 beds or 600 beds. But I'll tell you, during those 10 days when I was in the hospital, exactly 2 people sat down in the room with me, and one of them I gave him a direct order. I was in the military. I said, please sit down and tell me what's going on. And God bless him, he wasn't any more sure of it than I was. Another time, a nurse came in, pulled a chair up to the side of the bed, and sat there, leaned forward, looked into my eyes and said, I want to find out how you're doing. How are you doing? And I'll never forget that as long as I live. I have forgotten her name, but I know what nursing school she came from because I wrote a letter to the dean after that and told him how much that meant to me. All the time that I was there, that nurse is a part of my story as I remember that season of my life, a difficult season of my life. I'm fine now, but a difficult season of my life. And so I want you to sort of leave with this idea about the joy of medicine is those names and narratives. It's the joy of leadership too, by the way. For those of you who aren't directly in patient care, the names and narratives are the joy, but becoming part of somebody else's story, to me, that is the true honor and the true privilege. So I'm going to stop there, and I will leave you with this quote, actually. It's a frightening conclusion. You're the decisive element in the workplace. Your personal approach creates the climate. Your daily mood makes the weather. As a leader, as a clinician, I possess tremendous power to make a person's life miserable or joyous. I can humiliate or humor, hurt or heal. In all situations, it's my response to decide whether crisis will be escalated or de-escalated and a person humanized or dehumanized. And a very quiet, remember, while you're thinking of any questions, and we won't spend a lot of time, just to recognize that life, like the practice of medicine, is a practice of seasons. And there are those times when it is winter. And there are those times when it's very difficult, but winter is followed by spring and by summer. And when you think sometimes that everything is going well, sometimes those seasons come back again. And you just have to recognize that none of those seasons last forever. For me, it was a NICU rotation, and I ended up a pediatrician anyway. But getting through those seasons, the hope of knowing that spring is coming, the hope of knowing that there's summer to follow spring is part of what I think carries us through those very, very difficult seasons as well. I'm going to stop. I'm going to unshare. And I will see if anybody has any questions. I know I went a tiny bit on the longer side, but I wanted to sort of get through kind of 4 different sort of phases in this whole thing. And guys, you guys get a lot of credit for being here on a Saturday morning. God love you.
Right. So I'll do the Q&A. I wasn't able to properly introduce myself before. So my name is Hamza. I'm going into a BSDO program with the Seton Hill University of Seton Hill University and the Lake Erie College of Osteopathic Medicine.
Congratulations.
I'd like to say thank you for mentoring and teaching us.
Sure enough, Hamza. Nice to meet you. Are you from up that way?
No, I'm from New Jersey, but I'm here in Greensburg at the moment.
I'm going to ask you, where are you from in New Jersey?
Addison, New Jersey, Middlesex County.
Yep. I'm a Rutgers grad, so I know that part of the woods.
Nice. All right. The first question we have comes from Chelsea DeLeon. So you mentioned during your talk that technological advancements such as EMRs have discouraged connecting in certain patients. In your opinion, what are other systematic or organizational challenges that have caused challenges to the patient-physician interaction?
I think one of the ones we have to kind of navigate around is the fact that we carry this distraction device in our pocket. So I mean, I wouldn't do anything without it. The ability to be able to look up anything, anytime, is just unbelievable. I mean, it was textbooks when I came through this, but it also, I point to that as a major distraction, both from a leadership standpoint and from a clinical standpoint. And I would really encourage people to be cautious about accessing that in your personal relationships, in your relationships with your children. I tried very hard not to be on it around my kids, but even around our patients, as we're moving through the hospital, and as we do, we text and we walk together. So, I mean, to me, this is one of the biggest things. And what it's done is it's generated the myth of multitasking. We believe that we can do 2 things at the same time, when really psychologists, psychiatrists say that only 4% of people can actually pull that off. For the rest of it's serial monotasking, which means I go from one task to the next task. And I can do it if my caffeine level is sufficient, but otherwise it's just this sort of blurred waves of me trying to focus on one thing or another. So I would say from a technological standpoint, to me, that's the biggest thing to be careful of. And I know I sound like a curmudgeon, a baby boomer, a guy that's, approaching towards the end of his career, but I do think that it's a major thing for us to pay attention to.
Right, thank you very much. Now, our last 2 questions are more personal questions. So what has been the most rewarding part of your career?
Wow, that's a tough one. The most rewarding part of my career. Boy, that's hard. That's a hard one to answer because somewhere in the middle of it all, or towards the second third, I had a friend tell me something. As I left the military, after having been in the military since I put a uniform on when I was in my late teens. So I realized that an awful lot of my identity was tied to that. And part of the process of me leaving the military was sort of shedding that to the degree that I'm able to and beginning to see myself differently. He said to me that you have to believe at any step along the way that your best years are still ahead of you, and it's a mental exercise. And so the first answer that came to my mind is the most rewarding part of my career seems to always be the piece of it that I'm in. I keep telling myself I want to go back to be general pediatrics, but candidly, I haven't practiced directly since before COVID because of the crush of being the vice president for population health. In this role as a vice president of population health, not in the military, I've become aware of things that I didn't know existed. And I wish we had time to talk about it today. But if you would have asked me in 2015 or 2013 or 2012 about structural racism or privilege, I would probably have not even known what you were talking about. So I really feel like in terms of the steepest part of the learning curve, it's happened for me in these last 7 years, living in West Baltimore, being around people who did not come from a privileged background as I did. And so I would have to say that in terms of personal growth, to answer that question, it's really been this last decade. But I do hope to be doing general pediatrics again soon when all the dust settles, or peds pulmonary or something.
All right. Thank you for sharing more about your learning curve, Dr. Callahan. And now finally for our last question. Given you wear multiple hats in academia, public health leadership, and volunteer work, how do you manage your work-life balance?
Not well. And I will admit that. And this is a separate, longer conversation of learning about myself. I grew up in a household where the definition really to be was to do. And I didn't realize how deeply that impressed upon me. So I have not been as good at this as I wish I was. I am thankful as I look back that I've had a partner that I've known since we were both in high school together. We dated each other's best friends, and then eventually broke up, became friends in college, and then we've been together since college. But she's held me accountable. But I wish I was better at it. I really wish that I was better at that. And so I am paying more attention to it than I think I used to. My kids will say that I was there for them. I wish I was there more when I look back on it. And so I would really emphasize to people, one of the practices that we did do that I think really was helpful is that even when I was a medical student, there was 24 hours out of every week where I did not study. And those who loved me knew that I was going to be available, to them during that period of time. I'm not the brightest light bulb in the box, to be candid with you. And so I had to study every night and all day Saturdays. But usually from Saturday night to Sunday night, I didn't study. And my wife, and then later my children, I had 2 children while I was still in medical school, could count on the fact that I would be available for them for those 24 hours. I think that is a good practice. I had people tell me that you'll never pass medical school if you take a day off from studying. I said, well, then I won't pass medical school. So, but I did fine. And here I am. So I will tell you that was a really helpful practice for me. And we still try and do that to the degree that we can. COVID sort of upended it, to be candid with you, because most weekends I'm checking on our various we run operations 7 days a week, so I'm checking in. But I would encourage everybody to think hard about that 24 hours a week.
Right. Thank you very much, Dr. Callahan. These are all the questions we have for today, and we really appreciate you taking the time to mentor us today.
You're absolutely welcome. Thank you for the privilege, and best to you all. Minahil knows how to reach me. If there's anything you'd like to follow up with, I'd be happy to exchange ideas or touch base with anybody. So thank you all very much. Have a great rest of your weekend. Take 24 hours somewhere in there, though.
Thank you so much.
Bye-bye.
Now we're going to conduct our closing session with our quiz and future session dates. The link to the quiz for this session is now live, and as always, you'll need a 70% or higher to pass and receive certification, and the link to the quiz is being sent in the chat now.
For our next session dates, which will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. Our next live session will be Saturday, March 4th at 10 a.m. Eastern Standard Time with another physician mentoring us in internal medicine, policy, and academia. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing. Thank you.